Let me start by introducing briefly myself. My name is Anna Langer, and I'm a professor of the practice of public health in the Global Health and Population Department. I also represent the Global Health and Population Department on the LEAD Fellowship, a program that we co-host with the Harvard Global Health Institute. So let me introduce briefly our amazing speaker for today. Her name is Ifrah Abdi. She's a certified nurse midwife and a graduate of Edna Adan University Hospital in Somaliland. Ifrah has worked at Edna Adan University Hospital as a midwife for the past 18 years. In Somaliland, Ifrah trains traditional birth attendants in rural villages to help improve outcomes during pregnancy and childbirth. Ifrah presently serves as the Associate Dean of Nursing at Edna University Hospital and is a recent graduate of the Masters in Global Health Delivery program at Harvard Medical School. Ifrah's thesis project at HMS assessed factors that impact maternal health outcomes in Somaliland. We are really thrilled and honored to have Ifrah Abdi as one of our 2022 LEAD Fellows for promoting women in global health. As I said before, this is a collaboration between GHP and the Harvard Global Health Institute. Welcome, Ifrah. The floor is yours.
Thank you, Anna. Thank you, everyone, for this wonderful opportunity to present my research, and I'm honored to be here today. Good morning, good afternoon, whatever times for you. I will start. Can I share now?
Yes, please, go ahead.
Sure. Can you see my screen?
We can, but you may want to use presenters view. Perfect. That's perfect now.
Okay, as Anna said, I'm a nurse midwife. I've been working in low resource setting for over 18 years. My passion of helping in the medical field started very early when my dad had a sudden heart attack, and there wasn't any medical professionals back then. So I used to try to help him at home, and my passion of helping started from there. The only medical thing that I can study was nursing, which Edna started in School of Nursing. There was a long civil war, and all the schools and everything was bombed and closed. So I was one of the first batch of nursing that being trained. So working over 18 years, having all that experience, delivering more than thousands of babies. I did my research with the Harvard Medical School and went back. And so the result that I get it was beyond the one I thought I knew it. I was sitting in a delivery room just waiting for moms to come or going out in the field and helping them, but I didn't know the number and the extent of the need that existed unless I went out and do a research. And this was one of my first research that I did, but it will not be the last one. I start to do a national one now with the Minister of Health. So I'm assess factors that impact maternal health outcomes in Maroodijeh region, which is Hargeisa, the city, capital city of Somaliland. As you see the pictures here, I took those while I was doing the data collection. Some of them, not just the one that laying that have the blue, but the rest were and actual pictures that had been taken. This is a little vignette story that I deal with while I was in back doing a delivery. There was a lady that delivered in the rural areas, and there wasn't any healthcare professionals around. So there was a traditional birth attendants that were helping her to deliver the baby. After like more than long hours of labor, the lady had a ruptured uterus. The TPA couldn't figure out what was going on. The mother was bleeding heavily. There wasn't any ambulance to call. There wasn't any cars around, so they take her by donkey carriage. They travel almost 4 hours to the nearest healthcare facility. When they reached the facility, she was already in coma. She had her uterus removed, but instead of taking her emergently to the operating theater, she has to get a consent from her husband to approve that her uterus has to be removed or not. So instead of saving her there was another step that we were dealing with, which is like getting a consent to save her or not, which was another challenge that we had all the time. After she get approved and get so many bags of blood, they open it up and find out the baby was laying on the stomach, and remove the fetus was dead. The mother took like almost 10-14 days to recover. So when she wake up, one of the surprising things that happened again was that I witnessed. She asked about her child and said is dead, and they mentioned that her uterus was removed also. So she cried immediately, not because she survived, but because she couldn't have any more babies. And so that was like really kind of shocking for me to see a woman going all that problem, but at the end, not even getting recognized for all of the problems she was going through. So a little history of I think Donna knows already about Somaliland. Was a This is a little history I get it from Google. Being under Britain protectorate, it was in Arab Sultanate for 17 years. It took independence in 1960. United with the southern Somalia, there was a fight that was going on for over 30 years in 1991. The northern part that I am from took they separated. They still one country, so call it Somalia, but in where I grew up and stays where the red circle is, and it says Somaliland now, but it doesn't have any international recognition. Population there is 5.7 million. Somalia has a poverty rate of 73, according to the UNDP statistics. Maternal mortality ratio is 692 per 100,000 live births, which brings like to the second or the first high mortality rate in the world. Life expectancy is about 58. Literacy is 48%, and women's literacy, which I collected myself during my data collection, was over 70 for women. I did my research on Edna Aden Maternity Hospital, which I worked, and another 3 MCHs around the city. The catchment area was about 2.2 million. Here is some of the pictures I took while collecting data. That wheelchair is homemade, handmade wheelchair by carpenter. There wasn't any working wheelchair there, so they needed to transport moms from delivery to the maternity ward. So they took a plastic bag and constructed by themselves. The maternity ward don't have any pillows or bed sheets, so the moms, when they come in, they have to bring their own. The delivery bed was all torn out, and there was all blood everywhere. Here, the 3 bags, the red, blue, and green. Interestingly, it is the sterilization machines that we use of the MCHs. You know, we heard about infection control and, you know, how we have to not sterilize the sets and all that, but it doesn't happen where I'm from. They use these 3 buckets to use the hot water on one, bleach on the other, then antiseptics, and use the equipment again. which was like really, really shocking for me. We're trying to save mom's life, and a healthy mom can't come and catch a disease or HIV or like anything else because of the equipment that we use, which was very heartbreaking when I find it out. Because where I was working before had a sterilization, and I thought every MCH has the same, but I find out that it didn't exist. The goal was assessing factors that impact maternal health outcomes. The time that I spent collecting data was from July to December. I did quantitative and qualitative data collections. I used questionnaire that took 1 hour, and I for the qualitative, and I interviewed 202 women. Also, I look for patient records. For the qualitative, I interviewed 18 women for 60 to 90 minutes. Also, I did an ethnographic observation, which was the first time I did it, and it was the best that I have done. And you will see the results later on. Here is the conceptual framework I used. I was looking for social demographic disparities. I was looking for social economic burden, culture, health work, health facility infrastructure, and leadership and governance. Here is the inclusion and exclusion. Like inclusion was woman should be over 18, and she should have a record in a file, or she has she visit one of the facilities at least once, and she won't have any health conditions that won't allow her to participate in the study. So after I collect the data, and here's one of the shocking results that I find out. Only 11 women had 11% had a prenatal for their 9 months pregnancy. 6%, although the WHO and all the national said each woman has to have an access to check her blood work before she delivers for the HIV test. Only 6% was tested out of 202. Over 90% of the women that I interviewed had spontaneous abortions, which is very high. The women that deliver either at home or at the hospital had their PPH were almost 60%. So 60%, 76% of women that deliver had some time of postpartum hemorrhage. And we know that hemorrhage is one of the leading cause of death for women. So here's demographic characteristics of women, where they live in, their income status, if they were get help from NGO, if they were employed, and if they had any formal education. So if you, as you see the education back there, almost 50% of women that I interviewed didn't have any formal education. Here was the result of the percent of women that had infections was 37%. Postpartum depression was 20%. Postpartum hemorrhage was 41%. I did a percentual method on qualitative. So we explore women's journey of care seeking and assessing women's socioeconomic impact on maternal health outcomes. I did a structural interview for 60 to 90 in-depth interview, and as I did ethnographic observations. So I visit their homes and see how they were living, what they have, and their journey of care. So there is 4 emerging themes came out intertwined, which was barrier to access maternal health outcomes. There was a relationship and an accompaniment, lack of autonomy, that they can, even if they reach the healthcare facility, they will not have the authority to consent for themselves, and there was a complications that came with going to the hospital. So here's the examples of some of the women that I interviewed with. Like public transportation was not reliable. Women in labor are forced to work hours. The other ones that she has to spend almost $1.50 to go and spend on transportation, which was one of the problems, that they stay back at home and they delayed, and the complications can arise from. Here is lack of relationship and lack of accompaniment, that a woman goes by themselves to the clinic and come back and they don't have the support that they need while they get in the care they need. Lack of autonomy, unable to make their own decisions. Like if they, as I mentioned in my vignette, if a woman needs a cesarean section, she has to get approved by her husband or father. Just a male figure has to sign it off. Otherwise, she will die right in front of us, and we cannot do anything. As a midwife, I have seen it, and it happened. It still happens. Here's the complications of arise while they still. Some of them even complain that going to the clinic, there were still complications that were happening, like being in hospital and like there wasn't any healthcare workers, and they keep calling the nurse, but the nurse wouldn't respond, and she had a uterus rupture in one of the clinics, which was very sad even to know about. Here's the ethnographic observations I did while I was going homes. So the interesting thing about that mom was she had few kids playing around. A lot of them couldn't go to school because of financial problems. And when it reached lunchtime, she just went back while I was writing my notes, and she bring out this precious little baby girl. This girl, her name is Parwako, and she never left home. She was inside the whole time. She was on a little tire and a blanket. So I asked her who she is, and she said, this is my little girl, and that happened, that she had a complication of, prolonged labor, cerebral palsy, when the baby stay in a cup for a very long time and lack of oxygen. So she delivered it at home. She have a declared example of, birth complications and home delivery, and never have any access outside. So when I left there, I really, I couldn't sleep that night. I was thinking about that family and the baby they had. So I went back to my colleagues. We collect money and we bought that wheelchair and those clothes. When I came back, that I couldn't imagine the happiness of the mom. Also, the baby couldn't speak, but I can see and tell that she was so happy. Their sisters took her outside the first time, which was, I couldn't get that if I didn't visit home and been introduced to the ethnographic, which I thank my instructors all that really exposed that knowledge that I didn't have before. Here's the mom you see on the top, that I was checking her blood pressure. She had a preeclampsia when she delivered her baby, but she never got checked again. So there is no postpartum check when they leave the hospital or the MCH. So that was the first time after 6 or 7 months of delivery that she's getting checked. So one of the reasons they were even coming was we were giving her a free check. So that was one of the encouragements for them to come out and talk was, not just they were saying what they need, but they were getting the care they needed while talking. Here's on the bottom, that mom had a thyroid tumor that she never shared with anyone. She couldn't swallow. After I seen her situations, I transferred her to, I refer her to one of the doctors that work, and I was getting her medical treatment. Well, this was another benefit of visiting homes and exploring what was happening inside. I also did a focus group discussion with healthcare providers and nurses, midwives, and doctors, and they all have a different ideas of like not getting the equipment they need, not having enough healthcare workers, and complaining that moms come late and all the complications happen when there's no interventions before. So here's the conclusion. Education was number one. If women were educated, she could have read the warning signs, she could have communicated better. Employment, you know, financial, like all these were, you know, barriers for them to go and reach their health. So on my discussion, like I looked through at different countries that improved their maternal health, like Zimbabwe, and they had a high postpartum hemorrhage, but they trained community health workers, and there was like interventions and TPAs, and that lowered their level. Here's the limitations and some of the strengths and limitations that I had. This study happened in COVID-19, and although we don't even have the precautions, and we were dealing with, you know, one of the MCHs that I was collecting data lost to community healthcare midwives. So I ended up staying for 2 weeks, not collecting data, and trying to see if somebody can replace it. But when we tried to communicate with the Minister of Health, we find out that they were not even registered, and they were just working there for over 15 or 16 years, which was another shocking thing that I find out from there. There's the conclusion: health system strengthen staff and space as both farmers that help and address women's healthcare needs. Paul Farmer is one of my inspirational and in my icon, and I like to mention him for the great work he did and devoted to the people, and that's the moral of my research was behind. He was behind it. Thank you.
Thank you very much, Ifrah, for sharing with us. If you could stop sharing the screen now, for sharing with us the highlights of your amazing work under very challenging circumstances. We have time for questions and comments. If anyone is interested in asking a question or making a comment, please raise your electronic hand or type it in the chat. In the meantime, I may start with one question to you, Ifrah. I wonder if you used the 3 delays framework that was published like 30 years ago by Tadeusz and Main, that organizes the different delays that may lead to a maternal death, into delays in recognizing a complication, delays in reaching the health facility, and a delay in getting the care you need once you are in the facility, and that is closely linked to quality of care. Because I think that in the findings that you shared with us, you provided incredibly important examples of maybe each of those delays.
Yes, yes, I did, and you can see from each step that there was a first of all, women do not access their care because of the distance. which will bring a delay. Not healthcare workers was another delay. Also, there was an addition to that, which was not being able to sign by themselves, even if they came there, which was the biggest delay. That can cause somebody to die right there. So the 3 delays were a parameter that I was using, but more came up too.
Thank you. Thank you very much. Any questions or comments? Maybe Donald, I see that you have something in the chat. Donald says, I want to thank you for doing this work and presenting it in such a graphic way. It really did remind me of the conditions I observed in Hargeisa and Mogadishu many years ago, and best regards for your future work. Thank you.
Thank you.
Oh, I see that Flora has her hand raised. Flora, go ahead.
Yes, thank you very much, Ifrah, for this presentation. It was really, really insightful. I'd like to understand, I'd like to find out from you, the women in Somaliland, do you think if the delays in getting to the health facilities were not there, do you think they would still prefer to use the TBA, the services of the TBAs? And if so, why? That's one question. And the second question is, well, in Nigeria, for instance, you have, in some health facilities, the cost of care is actually lower than some TBAs, but yet you still have people, especially in the communities, still prefer to go to the TBAs to access care. Some of the reasons given are that the attitude of the TBAs are better than some of the health facilities. What are things like in Somaliland? Is this the same, or are there peculiarities about the TBAs that make them more attractive to the people? Thank you.
Yeah, that's a good question. Thank you for. It's very much the same. Plus, TBAs get trusted more. It was going on for so long. One of the interviews, when I was interviewing women, like their in-laws or their moms were the biggest influence, and they wanted to get delivered by TBAs. Some of the moms had the same TBAs that delivered their mom, and their grandma was still there working and getting the clients more than the hospitals. So there is a trusting between TBAs and and the patients. Also in Somaliland, there was not integrating TBAs and like the healthcare personnel. Like myself, when I was getting training, only TBAs were around, or an older healthcare like midwives. There was only 2 midwives when I started. So in my how I been told was, TBAs don't know anything. Don't listen anything they did. What they do is wrong. That's how I get trained at first. So when I went out to the field and I find out how many lives they saved and how kind they were to the delivering moms, and all the ideas I get out, I found out that they can be part of the crew if they get recognized, if they get the training done, if they get the right equipment. They can work out and save lives as well. So there's no connection between the healthcare workers and the TPAs, but I feel like still patients trust TPAs more than the healthcare professionals, because if TPAs cost less. Like, she can go to your home, you don't have to travel to them, they come to your home, they stay with you, they stay at night. Even if the mom goes on labor for 2 nights, she will stay with her instead of leaving them. So it's very much the same.
Thank you, Ifrah. We have another question in the chat from Olivia Mulvey from the Harvard Global Health Institute. Olivia, I will read it out loud, but please feel free to elaborate more. The role of the TBA is so important. If the role of the TBA is so important as you described, what type of programs and curriculum exist in Somalia to advance their training or medical knowledge? How would a TBA advance their training?
About 4 years ago, I trained traditional birth attendants. I used to go out in the rural areas, and the reason we started those training was we were getting, you know, every mom that we getting from rural areas die. So because of like ruptured uterus, because of infection, because of all that. And so we, you know, get a questionnaire who, you know, you were dealing with before you come here. Some of them had, you know, like breech presentation. So a leg comes out, and that's supposed to be like a cesarean section, but they are out in the rural area. So, you know, there's cases happen that a TPA cut the baby's hand, like, and then transferred the mom to the hospital, and they both died. And so we kind of pilot you know, training. So I was in charge of that. I went out in the rural areas. So we kind of some of the traditional birth attendants were herding their sheep somewhere, and we had a car and we look for them and we bring them to the city. The training that we were given, they were watching us what we are doing. They can't read or write, but they were just like watching how safe, how you deliver safely, and we give them clean sets that they did the core tie a clean set, and also in each 5 or 6 of them there was like a phone that we purchased, and so they can call in case of emergency. That happened within 1 month. We trained 7 traditional birth attendants. So 1 year later, we went back to get like see how their training helped, and they really improved. And we were not getting from that area that we trained, we were not getting that much emergency out. So if the training we were given was just they watched what we were doing, there wasn't any additional else. But I feel like if they and it's something that I want to share with the Minister of Health, which I'm doing my research was only to 4 different areas in the city, but I'm expanding to all the regions in Somaliland. And TPAs will be some of the additional thing that I want to add it to when I expand my research, because I see the benefit that you can get it from when you train them right and count them accountable. Then they will have that responsibility to, you know, to work out, and they raised and be payrolled and be paid. And so that would be something that I'm planning, and hopefully they will accept it, and we'll develop a curriculum for them as well. But I feel like TPAs is a great addition to the healthcare industry.
Thank you very much. Any other questions or comments? I see something else from Flora. Do you have a mechanism to link children born to women living with HIV to antiretroviral treatment? How do you involve the TBAs in preventing mother-to-child transmission of HIV? Great question, Flora. Thank you.
Yeah, Flora, that's a good question, and unfortunately, I don't have a right answer for that. As I said earlier, there is no even proper sterilization. So if like one of the MCHs in the suburban, if 5 mothers come at the same time and they deliver, and there is only 2 sets there, they just wash it out and take right away and deliver the other moms, which is increasing the transmission of infections. So plus the mom do not get their you know, HIV results test before they deliver. So you never know who you're delivering with, if they are HIV positive or negative. The antiviral treatment. There are some places that offer, but you know, you cannot tell who you send it there unless you check. So that's, you know, a very low, and it needs, you know, improvement from there. TPAs, they don't you know, they don't give injections, they don't cut, you know, they do just our traditional delivery way. So we told them to put the gloves in when they delivering it, do not cut and all that, but you cannot tell how to prevent the transmission if you don't check them out. Just washing hand, being clean, using clean gloves, you know, keeping the mom and the baby clean so they don't get an infection. That's the most important thing that we teach. But you know, it's more broader when you're dealing with HIV, but you don't have the right equipment. There's no even labs in many of the healthcare and MCHs.
Thank you. Any other question or comment? If not, I have one. You mentioned that for your next study, you had the support of the Ministry of Health, or maybe they are participating in the study, I'm not sure. What are their priorities at this point? What are they planning to do in terms of policy and maybe investment in MCH that would potentially provide some means to mitigate some of these very, very difficult challenges that you are facing in terms of maternal health?
You know, first I was just you know, working in a maternity ward, and I didn't know the extent of this problem was all. So when I finished my master's and I went back, I sit with one of you know, high officials and Minister of Health, and I said, this is serious, you know, I did this, and you know, I want to share and see like the extent and what's going on. So you know, they were you know, very welcoming, and they said they will help me out getting help from TED, which is an international NGO that will provide the funds to do a national data collection for maternal health. I myself proposed to, you know, help out, which was one of my when I finished the thesis, I brought up to make an NGO that makes home visit. You know, that's the only way that we can minimize this. Women cannot travel. We can deliver the care to them and give them the care they need. There is new graduates that come out every year. There is a high unemployment rate. So like, just to get advantage of all the nurses and midwives coming out and graduating, to start a home visiting program that goes homes, and each mom will have a card and have like her blood checked, her BP checked, her baby weight and everything. So when it's time for her to deliver, she can have all that written up and goes to the closest clinic or even get delivered at home. So I proposed that idea to them, and you know, they liked and said, let's do a national research first, and you know, we will come out with that. Either we might work as the Minister of Health, or I started a nonprofit organization and they support. So that's what's next in line. But my plan was to start a home visiting program.
Thank you so much, Ifrah. I'm so happy we are able to support at least some of your work through the LEAD Fellowship. And please count on us for whatever you may need to keep doing your important work.
Thank you so much. Thank you.
If there aren't any further questions or comments, I will give your busy schedules 20 minutes back, 18 minutes back. Thank you again, Ifrah. We'll be in touch. Thank you all for your participation. Have a good afternoon, good evening, everybody.
Thank you so much. Thank you all.
Bye now.
Bye. Bye, Donald. Thank you.